So after watching my students practice this the other day, I thought I should create a video kind of explaining some of the reasons we do some of the things that we do, so sort of explaining the whys. When you go to check off on your skill station, it's kind of a nerve-wracking experience, so you want to prepare as much as you can beforehand. So usually the proctor will give you a couple of minutes to evaluate and look at your equipment. So I'm going to look through my equipment. I know I'll need a bag valve mask. I have the mask and the bag valve mask. I have my oxygen cylinder. I have a couple of different types of OPAs. I know these are going to be too small, so I'm just going to move them a little bit off to the side. I have my syringe, my King Airway, end-tidal CO2, my lube, and my tube holder, and my stethoscope. And I'm just going to take my stethoscope and go ahead and put it around my neck. So I have it there ready to go. Now I have my gloves on already, and I even have safety glasses, so that's my personal protective equipment. I encourage you to go ahead and put that on before you even get started so you can get the point on that. When we start the scenario, the instructor will give you some sort of scenario, and it'll probably be something similar to you have a patient that has gone unresponsive, the family's present, they said there's no trauma involved, and you have a partner that can carry out your orders as directed. So you arrive, and I got PPE, I make sure my scene is safe, I only have the one patient, there was no trauma involved, so I don't suspect a neck or back injury. The nature of illness is that he went unresponsive, and at this point I'm not going to call for any additional resources. As I approach my patient, I get my general impression, and he is unresponsive on the floor. I don't see any major bleeding or other life threats, so I come up and determine responsiveness. Hey, are you okay? And he is unresponsive, so I tell dispatch that I might need some backup. Head tilt, chin lift, jaw thrust, open the airway with your thumb, your triple airway maneuver, and I check a pulse, and I do this for at least 5 seconds, but no more than 10. And he has a pulse rate of 60, but he's not breathing. So I'm going to find my OPA, measure it, of course come in from the side and rotate it around, grab my bag valve mask, and begin ventilating. And you want to deliver 1 breath every 6 seconds, which works out to be about 10 times per minute. I'm going to turn the ventilation over to my partner because my pulse ox is showing a little low, only about 85%. And I'm going to attach this to oxygen. So attach it to oxygen. Oops. And then I will set the flow rate. I'm going to turn that up to 15. That looks good. So my partner is ventilating 1 breath every 6 seconds. I have my oxygen, and I'm going to insert my supraglottic airway. Now this may be something that medical direction tells you to do, or you may be able to do it by protocol. But before we do it, I want to check my equipment. Now this says to insert or inflate about 50 to 70 milliliters of air. So I have that in my syringe. And I'm going to test to make sure that the bulbs are inflated and they don't leak. And they are. So now I'm going to take the air back out so that they're completely collapsed. I like to go ahead and pre-attach my end-tidal CO2. And then I will insert my, or not insert, but pre-place my tube holder. And my partner is still ventilating, so I never interrupt my ventilations. That's about right. Now right before I go to insert this, I'm going to lube the tip of my airway. Get that all lubed up so it's good to go. Have it in my right hand. I tell my partner to stop ventilating. I pull out the OPA and just pull it straight out. Set that to the side. Tongue jaw lift. Come in from the side till you get past the back of the tongue, and then you can insert it the rest of the way, and you'll get it in there until you meet resistance. And you kind of want to note how many centimeters that is. So I'm 14 at the teeth. I then inflate it. Take my syringe off so that way the air doesn't come back out. And I notice my pilot balloon is still inflated, which means the balloons down in the esophagus and the hypopharynx are still inflated. Give it a little bit of just a little bit of a snug pull to make sure it's snug. And then I will attach my BVM and start ventilating. Now, turn this over to my partner to keep ventilating 1 breath every 6 seconds, because I'm going to take my stethoscope and I'm going to listen first over the epigastrum, because I should hear nothing in the stomach. And then I will hear listen over each lung, and hopefully I will hear bilateral breath sounds, and I will see chest rise and fall. So I'm pretty certain I'm in, but I'm going to confirm that with my end-tidal CO2. But I have to wait until I get at least 6 breaths in before I can look at that. I should see that turn yellow. So I am in, I think. So I'm going to place my tube holder in place. My partner's continuing to ventilate. I want to tighten this, but not too tight, because I can cut off venous return and make things like head injuries worse. Once I have that in, I can then twist the yellow to snug the tube into the tube holder. I like to have the tube holder attached to the patient first and then attach the tube to the tube holder. And at this point, can continue to ventilate. 1 breath every 6 seconds. Go ahead and recheck a pulse to make sure I didn't lose a pulse during all this. And I still have a pulse. And at this point, we can prepare to transport or go ahead and finish our assessment because we have the airway taken care of.